The key to safe administration of drugs for sedation is to give small incremental doses titrating to the desired effect.
The two classes of drugs that are commonly used today for moderate sedation include opiates and benzodiazepines. In the opiate class, the most commonly used drug is called fentanyl. It's a very short-acting opiate that has the benefit of wearing off quickly, so that if patients need to go home after their procedure, they're very alert.
Fentanyl in large rapid boluses can cause chest wall rigidity, although the amount of fentanyl typically used for moderate sedation likely would not cause this kind of reaction.
Two other drugs in that category include morphine and hydromorphone. They're longer acting, and for patients who are either inpatient or going to have longer procedures, it may make sense to use drugs like morphine so that you limit the number of times you have to bolus fentanyl. There is another class of opiates called ultra-short-acting opiates, which one would theorize would be even better than fentanyl. The problem with the ultra-short opiates is that they have more common side effects like nausea, vomiting, and dizziness. And in most situations, for patients need to go home, that is not ideal. They include sufentanil, alfentanil, remifentanil, and lofentanil. They have their uses, but mostly for anesthetic purposes. In the benzodiazepine category, the most commonly used drug is midazolam, or Versed. It's really revolutionized the ability to do moderate sedation because it's a great agent that provides anxiolysis, reduces anxiety. It's a fantastic amnestic, so people who don't want to remember exactly what happened have little recall of the procedure itself, and it's very short-acting, so it wears off. In addition, benzodiazepines have the advantage that they have very little respiratory depression. Since one of our major concerns with moderate sedation is maintenance of airway, the use of benzodiazepines instead of opiates, when possible, limits that potential side effect. I would categorize the use of opiates as a perfect moderate sedation medication if there's going to be pain produced during the procedure. So if we're going to do a procedure where there might be an injection or some kind of painful stimulus, then the use of an opiate like fentanyl will help reduce that response. But many of the procedures that we do, like CAT scans or MRIs, they produce no stimulus. And all you really need is anxiolysis. And in that case, benzodiazepines like midazolam work well, even as a single agent. Other drugs in the benzodiazepine category include diazepam or Valium, or lorazepam and Ativan. They're older drugs, they work well, but they're definitely longer acting than midazolam. Again, in patients who are going to be monitored as an inpatient or in procedures that are going to last much longer, then the use of diazepam or lorazepam may make sense. But in most cases, midazolam is an agent of choice. The drugs that should not be used for moderate sedation include barbiturates, ketamine, etomidate, and propofol. Although they are excellent agents for deep sedation or anesthesia, their use in moderate sedation should be limited or not at all. And the reason for that is the medications themselves have a much shorter therapeutic window. So a particular dose may have an expected effect in one patient, but that very same dose may produce deep sedation or apnea or hypotension in another patient. And because of the unexpected variable response that these drugs can produce, they really need to be given only by people who are experienced in advanced airway skills or in how to manage high hemodynamic compromise with a very broad library of resuscitative medications. The adjunctive medications that can be used in moderate sedation really depend mostly on the procedure. For example, if a procedure is likely to produce some discomfort after the procedure is finished, it may make sense to give a patient an anti-inflammatory medication or non-steroidal anti-inflammatory medication or aspirin to help reduce the likelihood that the patient is going to be uncomfortable afterwards. When adjunctive medications are going to be used, research indicates that the pain medications should be given before the painful stimulus. This ability to block the pain signal reduces the eventual pain sensed after the procedure. We call that preemptive analgesia. In situations where the medication was not given before the procedure, certainly it can be given afterwards, and most of the time it's very, very effective. Other medications that might be used as an adjunct medication in moderate sedation depends upon whether it's likely the patient is going to have nausea. If the patient is likely to have nausea or vomiting, then antiemetics given before the procedure would be very helpful. When there's an adverse drug response during moderate sedation, practitioners should be encouraged to report the event to pharmacy and to their process improvement coordination group. The collection of all of these adverse drug events can very often lead to modifications in protocols, in formulary, or in system processes that can help prevent those same kinds of reactions in future patients. The goal here is to make sure that practitioners feel that reporting the event will not lead to some adverse event for them personally. And so we want to encourage them. Another way that people do this is they call them near misses, and they actually record anonymously either an adverse drug event or a near miss. Either way, you want to be able to collect the data to help change protocols for the future.